So, okay, so let me just see. How do I start sharing my slides? Ravi, start sharing.
Yes,
All right.
Yes, ma'am.
You have disabled. Yeah, the host disabled participant screen sharing.
Guru.
So unless you make me a co-host, I cannot share.
Yes, ma'am.
Guru. Yes, ma'am. Now, right now, I just made you as a host, ma'am. Now, I think you can able to share the screen.
Okay. Okay. Notes go away, no? Ravi, when we are doing this?
Yes, ma'am.
The notes which we write underneath for our own memory, they
this
go
is
away.
currently not seen, ma'am. But if you want, you can share. You can save it also, ma'am.
What do you say?
Ma'am, yes, ma'am. Actually, what we wrote, what are the notes we write for our references will not appear in the display, ma'am.
Yeah. Because usually otherwise, in a regular thing, when you click the 3 dots, it usually says display mode and you can see it in the side.
Yes, ma'am.
Here it doesn't happen. Doesn't matter.
Ma'am, can you just run through your slides, ma'am? Second page.
It's not moving. I'm clicking.
It's not moving, ma'am.
No, it's moving.
Yes, ma'am. Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah.
Guru, shall we start?
Yes, Ravi.
Guru, everything is okay from your side?
Yes. Everything is fine. So probably we can start. Can you start, Dr. Ravi? Can you introduce Madam, please?
Yes, Guru. Yes. Good afternoon, everyone. Thank you one and all for joining the session of this Indian Psychiatric Society Karnataka chapter and online neuroscience education joint collaborative series on neuropsychiatry module. So last week we have spoken about BPSD, introduction and assessment, and this week will be a continuation of that. This would be on the management of the behavioral and psychological symptoms of dementia, BPSD.
Yeah. Ravi, can I start?
Psychiatrist, and she's a founder of Steps for Wellbeing and is former professor of psychiatry at NIMHANS, Bangalore. Thank you very much, madam, for accepting this session, and over to you. Thank you one and all for joining this session.
Thank you.
Thank you. Hello, madam. Madam is there. Good afternoon, madam. And thank you, madam. And Ravi and IPS Karnataka branch for giving me this opportunity to be part of this online educational program. And today, I think last week, Dr. Professor Matthew very elegantly talked about the various behavioral and psychological symptoms of in a person with dementia. And because it's very difficult to sort of delineate what is the symptom and what is the treatment, there are times when he also touched on them. So anyhow, I will go through it because we will look at some of the studies in much more detail. That's what I'm planning to do and how things have changed, because when we started the dementia clinic, a geriatric clinic in NIMHANS, it was 1999. And how things have changed from that time to now is what I would also like to sort of point out in the management, especially the psychiatric, the drug management. Okay, this is something like he talked about last week also, though it was described by Aloy Alzheimer. Actually, he gave more predominance to her behavioral symptoms, how she was paranoid, how she was hallucinating, and more than anything else, though there were some symptoms of cognitive decline. Okay, so one of the things which people have identified from day one is that this is, see, most of the times we talk about psychiatric conditions as functional disorders. And earlier, the functional disorders used to have a very pejorative sort of a connotation. But now we understand that it is more subcellular. But this is one condition where the psychiatric symptoms have a very clear anatomical substrate. But how it happens, that sort of a quizzical thing, we have not been able to solve. So there is an anatomical substrate for the symptoms, whether it is the cognitive symptoms or other symptoms. So all the symptoms in dementia are either ADL or BPS, behavioral or cognitive. And we usually talk about the cognitive when it comes to dementia, but ADL and BPSD are equally important. And when it comes to BPSD, it is not a single symptom like in a syndrome. In a psychiatry, we talk about various group of symptoms. And when you come to DSM-5, you talk about criterion-based diagnostic syndrome. And that's not the case in the case of BPSD in dementia, behavioral and psychological symptoms of dementia. They are a very, very heterogeneous group of symptoms, and what you may see in one person may not be there in another person. Some people may not have BPSD at all. But this is something which was recognized by most of the people, ratified by the IPA. But even today, it does not have any diagnostic validity and has been sort of ignored, though it is one among the most important symptoms of dementia, ignored by most of the people who are in the classificatory panels. And there are various clusters, and Matthew has already touched about them. One of the most important them is the aggression and agitation. The other very difficult one is wandering and pacing, and all restless activities of disrobing, picking, and various things like that. And the other one, which is a very withdrawn one, is the apathy, depression, anxiety, and of course, leading on to that restlessness is the mania part of it. Very pure psychotic symptoms. So you would find that the most common, I have put it as, what is the most common, and less common. So apathy, especially in Alzheimer's dementia, you would find that BPSD starts with apathy. Okay, so the less common I have written, you probably can have a look at it because these were already covered last week. And according to the diagnosis, this is not a hard and fast rule, but you would find that in Lewy body disease that there is always, often there are falls and there is hallucinations. Okay, so, and in vascular dementia, there are more often depression. So these are some of the things in frontotemporal dementia. A lot of disinhibition can be the first symptom, very odd behavior, repetitive behavior, and they can get a diagnosis either of schizophrenia or OCD. Okay, so this is something which we did in 2004 as one of our MD thesis, and this is what we found in our geriatric clinic at that time. Probably this has been repeated, the prevalence of BPSD in our client in the geriatric clinic in NIMHANS, but this is how. So you would find that apathy is the most difficult, is the most prevalent, and then sleep is the next one. All right. So the consequences are very many. One of the things is great burnout by the caregivers, whether they are family caregivers or paid caregivers. Highly distressing for the individual because the person is still there, because even when somebody has dementia, the person is still there and they are not able to, it is there. It is like a locker where you have got in your bag and it is locked and you have lost the key and you are not able to retrieve. So it's highly distressing to both the individual and also the carers, and often pushes towards over medication and consequences of medication, abuse, and everything. So we will look at the management now. Okay, so what are the options which are available? The first option often which we have to, I think there are people who are doing DM in geriatric psychiatry, fellowship in geriatric psychiatry. And because of the, the government policy, there are geriatric setups everywhere. One of the things, not only with dementia, but even with elderly who are showing some sort of a difficult behavior, The first option is to, just as we would do with children, is to wait and see. Because many a times that they are not able to express what they want. Probably once they are able to do that or get what they want, things will settle down. Sometimes ignoring is the best policy. You ignore it and things sort of, they are able to cope on their own and it settles down. So give it some 48 hours. If not, then we have to identify the cause. But the minute there is a problem, a small problem, which doesn't require that much of it, then jumping and addressing it is not a very good idea. It doesn't provide empowerment to the person who has dementia, because the person with dementia has equal rights and also has the capability to cope. So identify cause, and we will see one by one. Education and counseling, whom is it for? Both for the person and for the family members and the paid caregivers. Next one is environmental modulation or modification, and you would find that how great it is. It is such an important factor that often we forget about that, and we focus only on the person and not on the environment, including the paid caregivers and the family members, us. And then there are direct behavioral approaches, which is called dementia mapping, where you sit with a person and do the ABC at length over days or hours. Specific therapies, there are multiple of them. Medication, I'm sure many of the people, because you all belong to the either you are a neurologist or a psychiatrist, it's a very important aspect of it. And the last one is somebody is diagnosed with dementia. Even if they do not have BPSD, there is a need for prophylaxis. Yeah, this is a very good article, by Van. It's 2018. So if I give it to Ravi or thing, I think many of these articles people should go through, because there are good systematic review and meta-analysis of many of these BPSDs. Very nice. Okay. Maybe brief and limiting. This is something which we already spoke about. Always remember that the person has lived experience, has gone through life, has a lot of coping strategies, and we jump the gun by not allowing them to use the coping strategies. So that's very important. We still need to give a lot of respect to them and then help them to cope on their own rather than you showing them, because once they get the knack of it, when something else happens, they can actually fall back on that experience and then do it. People with dementia can still cope and can still learn. The rate at which they do may differ between you and them. That is all. So next we have to identify the cause. That's not the possible. Is it I think this also Matthew spoke about last week, but how do we go about it? Is it a new one? If it is a new one and acute, whether it is a delirium, and the delirium, is it from pain, from a fracture or constipation, retention of urine, or sudden hyponatremia due to medication or dehydration? It's so hot, and if somebody doesn't drink 1.5 to 2 liters of water, they can easily go into, and madam knows how my mother used to repeatedly go into hyponatremia and then become delirious. And if it is an old one and acute on top of an old, then look for what are the older things which were there, whether it is a COPD or any other sensory impairment. We recently had a very good lecture by Professor Leroy, who talked about, RCT, where they are using with people with moderate dementia to help them to use the hearing aid, and how it makes a difference in their behavioral, not only cognitive, but also in their behavioral symptoms. So it is important. If somebody may think, oh, they are old, they have dementia, why should they use it? They may not even know how to use it. But with the help of a diet, another person, Karen, she was able to prove, it was a very small sample, 15 or 20, but the difference was definitely significant. So all these things, even a drop counts. And then is it because of the medication? Because as Matthew said, at one point of time, they said that an elderly person is on 22 tablets a day. So anything could be interacting with anything else. It could be a new medication. It could be a medication somebody has started because, they are having pain. So anything could be, and that is something which we need to sort of And one of the important thing is many a times when people have Parkinson plus and then syndopa started, they can have hallucinations. Okay. And then, is it a psychiatric illness? Does this person have a history of psychiatric illness earlier? Okay. Does the person is prone to depression? Is there a family history of depression? Okay. So is there a family history of anxious? Is the person might have never received a diagnosis of anxiety, but by personality was a very anxious person? Has it become a syndromal one right now? So these are some of the things which we need to understand, because if you look at most of the literature, even the recent meta-analysis says that about 80% of the people with dementia have BPSD. But some of the studies say that up to 99% of the people with dementia during their lifetime. So when the dementia starts today, if they are going to live for about 20 years, somewhere along the line, 99, that means almost all of them, except a very, very few, will experience one or the other BPSD and will be a challenge for themselves, the doctors, and also the carers and the health professionals. So up to 50% of them can have psychotic symptoms and up to 50% of them can mood symptoms. So that is something which we need to constantly, when we are looking at dementia, once, we say, okay, after 6 months, but we also need to know that anytime the picture can change, and that has to be sort of tackled. Carer education is very important. We often think that's not, that they may not understand, even if they are paid carers. If somebody is able to teach them what is dementia and what happens, because many people say, oh, he is able to remember things from long gone by. Then how is it that he is disrobing now, or touching me now, or asking for food, if he can remember what happened in 1920? So there is a lot of need for training and educating and providing support to people who are family caregivers and, or paid caregivers. And that is what ARTC and Nightingales, they are all doing. So which is very, very important, because once you do that, people are able to be more tolerant. The incontinence is not a willful act, but the person is not able to understand, or not able to understand where to go to the toilet, so would rather pass the urine. So these are some of the things which we need to do. And you would find that Madam, in one of the thesis for the Jimmy Sebastian, has done a very, very, self-explanatory manual for carer education. And I think most of you should get hold of this and then provide your carers with this so that they understand what it is. And there is a chapter on BPSD also. Okay. This is something very important. I think the heading has gone. This is environmental malnutrition. This is so important that instead of talking about the person and sedating the person, this is more important in BPSD. Minimize environmental change, because what people have to understand is, if there is an environmental change and there is a lot of agitation and restlessness and sleeplessness, and somebody is going to be put on medication, within 4 weeks, it is not going to work, because it is the environment change rather than anything happening. Yeah, there are changes in the neurotransmitters, but it is not because of, it is much more, man-made rather than by neurological there. Neuro-Psychiatric. Stability is very essential. We had a staff nurse. Staff nurse mother had 10 children. So, and she was shifted from one place to the other every month. So naturally, how will the mother know where the toilet is? So stability and stability of caregivers is a very, very important aspect, and structure to the day. Like the children, we need structure to the day, structure for ADL, exercise, food, light exposure, food and hydration, sleep, because this is one among the most, next to apathy, circadian rhythm disturbances and sleep hygiene are very, very difficult with elderly. And activities are needed, because an idle mind will definitely, get into trouble. the lighting of the place, because we always talk about, even when we talk with the architect about how to light up a dementia ward, light from both the sides, no shadows, so that it prevents sound downing, and very bold grids to be avoided. That sort of is a very difficult thing for people with dementia. And the noise level should not be too low or too high. And there are courses on communication in persons with dementia. And even our department of speech and hearing used to do a lot of, training of carers with dementia, how to communicate with them. And we used to do role plays. Okay. Each one of them has to relate to the person rather than general. For a particular person, what does it? Because it also depends upon the personality of the person. A very apathetic person may need a slightly stimulating environment, and a very pacing and a very restless person may need a calming thing. Okay. And assessment starts with a very detailed assessment. The whole history has to be taken just as you would take in psychiatry, including cultural, spiritual. Why I say this is, I remember one of the dementia persons who was a very restless person. One thing which we were able to identify after a lot of discussion is that he was very fond of Vishnu Sahasranama. So whenever there was restlessness, we just told the person to start the first 2 lines. And he would keep for the next 30 minutes, he would be just chanting that and he'll be calm. Again, he'll become restless. But whenever the restlessness became high, the one thing which we could do was to help the relative to start the shloka. Physical health, psychosocial factors, because you may think that a pacing within a small apartment of 2 bedroom will be seen as a significant restlessness. On the other hand, in a village which extends from one street to the other, will be just a wall walking. So it always, we need to understand what is the psychosocial space and the circumstances of the person, and the analysis, antecedent behavior, and what is the consequence of any person's BPSD? Is the person given attention, cared for, sedated, or tackled adequately? So that is something which we need to ask every time there is a BPSD, which is a presenting symptom. Need for accurate descriptions. And I think people in psychiatry would know phenomenology. All of us, I hope you remember your fish and things like that. Phenomenology is the one on which we make diagnosis. Though now it is all, because of DSM, it is all criteria based, but still we need a lot of phenomenology to understand a diagnosis. What is the diagnosis we need to make? And it needs to be done with a lot of direct observation. You need to see it and also get a lot of written description by the carer, and also by other professionals. Okay, so so if you go to this, the options we saw: education and counseling, environment management, direct behavior, specific therapies. So let's go to the specific therapies, which are behavioral approaches driven by analysis. We talked about it, individually tailored, and then sustained effort. Again, let me tell you a very difficult, where we had to really think a lot. We had this elderly woman, and she had only one son, and the son was married, and he was in his he was in his late 40s, and she lived with the son and the daughter-in-law and 2 grandchildren who were teenagers. The son was an exact replica of the father. So whenever the son, and he had started to gray. So whenever he came into the house, the mother thought that it was her long gone husband and would approach him very, very, physically. And the son found this extremely difficult, but because this was in front of his wife and the children. So one of his ways of coping was to come back home after the mother slept, and go away to the office before the mother woke up. And this was a very big issue for him. And after, talking with him and seeing his father's pictures and everything, one simple thing which we suggested is whether he could grow a beard and change his haircut and things like that. So this is something which we suggested. I'm not sure whether it was successful or not successful, because every time you have to talk about it for the person than anything else. Okay. And at some point of time when we are not able to come up, because the person has to be dealt by the family members and they are not able to do it, you have to bring them into the hospital to do the behavioral modification by trained staff. For example, into NIMHANS or other dementia setup, inpatient setup, and where you can do a much more vigorous observation and then provide suggestions and interventions which are replicable when they go back home, because not everything we do in a ward is replicable in a home. So that is something we need to do. And one thing which can definitely help many of the family caregivers is providing a support group. And all the behavioral interventions are not only by the neurologists or psychiatrists. It is a multidisciplinary approach, because when there is constipation, you need a dietitian. When there is a sensory impairment, you need an audiologist. When you need a hearing aid, you need and when you have to communicate, speech and hearing specialist. It's a multi-domain, multidisciplinary. So this is a very good systematic review of the non-pharmacological interventions to treat behavioral disturbances in older patients with dementia. And this is one among those projects, and it is in BMJ. It's very good, but what you will be very surprised to see is what it sort of shows is whether it is the drug management or the non-pharmacological management, the effect is only moderate or medium. Many of them it is low, some of them it is moderate. That is all. So we need to learn to cope with that, and this is something which this article sort of highlights a lot. We will see that there. We will see that later. Okay, so some of the things which I thought I should put it down is Ajay is having, what is the behavior, when is it occurring, where is it occurring, what happens before, what happens after, what increases it, what decreases it, what happens as a result of the behavior, what does he get, how have we been dealing it so far, who manages them more often, what tactics are effective and what tactics are have not been found to be effective. Okay, and yeah, old and new, we already talked about it. And then one thing which we repeatedly have to remember is, one is the environment, the other is the medical etiology. Okay, fine. We'll go to the medical aspects of it. Okay, yeah. So I think I said about this, the context is in a very important environment. Small home, I already spoke about it when pacing is in a small home and in a big hall. And the reason being wait and see. Sometimes there is a need to ignore. For example, elderly refuses to take multivitamins. Just chodo. Whereas if he refuses to take, and he's a very, very bad diabetic, and then he refuses to take the insulin, that's a very different story. So what we should ignore, and since we are all adults and we know how to cope, and we have the lived we also live in this world, we should know what to stress on and what not to stress on. And I think that's something which we have to address. Whether the symptoms are towards themselves or to others. Okay. So the calls to the doctors will be less, to the hospitals will be less, if the person talks to themselves in a soft voice but never raises the voice. And if the elder sleeps, you all know that in depression, the attention is less, but in mania, immediately there is a ambulance to the emergency. The person is too weak. Even if the person is restless and aggressive, the attack will not be very severe. Okay, so these are also symptoms of disruptive behavior and unmet needs of the patient. But because of not only the context in which it is happening, but also the context of the person who's exhibiting it, it is not an emergency, may not draw attention, but at the same time, it is an unmet need, because this person talking to self may be isolated so much, is talking to self. So these are some of the things which we need to constantly remember when we are dealing with BPSD, environment and the person himself or herself. Okay. So these are some, again, the unmet needs could be lack of company, boredom, it could be pain, hunger, thirst. Okay. So overstimulation, we also looked at it. Okay. Particular, too many people visiting at the same time. Moving houses, I told you. I really felt very sorry for that nurse's mother because she would exactly spend 35 days in each house so that she could go around 10 children in about a year's time, which was very, very sad. Okay. So this is something which I just wanted to say, that the person is still there. The person, only if they have the capacity. So many a times they are doing the behavior is without a motive. So they are not doing it intentionally because these are people with dementia. They do not have the cognitive capacity or competence, because if you're called to write a legal aspect on them, many of them we would say, yeah, they do not have the legal cognitive capacity or the competence to do it. So when we are able to say that for a property, we should also remember that when we are talking about the behavioral aspect, many a times we think that it is intentional. Okay. Again, apathetic people are not taking a long time because they want to irritate you. Okay, so these are some of the things. So this is very important. Now there are lots and lots of guidelines of how to deal with BPSD in people with dementia. For example, earlier we used to have the NICE guidelines when it came out in 2006, and then we had the NIMHANS, not the NIMHANS, IPS guidelines for treating dementia, not specifically BPSD by I think Dr. Tiwari and Avasti, and I think even PT is there, Shivakumar is there. Okay, so but here, now there are more guidelines, New South Wales guidelines, you have the Canadian guidelines. So there are lots of guidelines, and then this is a Bendigo healthcare guideline. Mainly for certain aspects they focus on, for example, when it is agitation and aggression. When there is agitation and aggression, but you don't find psychotic symptoms, what do? And that is a very important thing, because you do not want themselves to hurt themselves and you do not want them to hurt you. So these are guidelines which are very clearly given. You can see there, go away, give them space, remove weapons or instrument like knife or screwdriver or things which can be thrown at. Do not stand in the front, stand at the side. Try to distract them. Talk about things if you know the person adequately, whether they liked certain, songs from the past time or activities, or like to go out, do that. Do not get into an argument, and suppose they say, somebody has stolen my specs. Do not try to, sort of rationalize, saying that nobody has taken your specs. You have forgotten it, you have misplaced it. That's not the way. What we are trying to say is to calm. The goal of the whole approach is to calm the person rather than rationalize and teach the person. Talk in a calm voice, and the ABC has been enough time. After the episode is over, the people who are all involved in the whole thing has to get together, debrief, and come to some sort of a conclusion. What should we be doing when it happens next time? And this is something which they put it up in many of the dementia centers there. So this is a Bendigo Health, and I have seen similar thing in the New South Wales, which is recently, about a week back, it has come out. Okay. And some of the other therapies which I've now been talking about is some of the therapies we will see. PET therapies, sensory enhancement. Before these are some of the therapies, but I would go here. I will skip this and go here, because in 2009, I think, I'm not sure what you can see. When I was in NIMHANS, we did a behavioral intervention for people with BPSD. But this was a MPhil thesis, so we took only 4 people, but we developed a model of the very individualized model, and it was about 90 minutes each session and 15 sessions. And and we published it also. We did the pre and the post, and it was all referred by the geriatric clinic. And you can see, these are the things which we did. Psychoeducation, problem solving skills, which involved pinpoint the behavior and the frequency, brainstorm with the family members for strategies, select a strategy using pros and cons, plan and rehearse without the patient, try out the strategy and give a feedback. So this is what we did. And this was done at the home of the person with dementia. And the other things were also included. There was a significant, but you just imagine, it was 15 sessions. Each session was anywhere between 6 sessions to 9 sessions. So the acting out behavior decreased, dysphoric mood because the person who constantly was facing a wall decreased. But what did not improve was the cognitive aspect and withdrawal and self-care. ADLs did not improve, cognitive aspects did not. So only the BPSD decreased, which is a very good thing according to me. Okay, so these are all the various therapies which you have nowadays available for people with BPSD. So we have already talked about the day structure. I cannot, sort of stress. I think I have to stress again and again, a person with dementia needs a day structure and all the paraphernalia which are necessary for a day structure. When you walk into a room, you should be able to see the lights on both sides, a big clock, probably a chiming clock, and facing that, and various many pictorials of, if the person is not able to, no longer able to read, and then what time is what? 8 o'clock is breakfast, is 8 o'clock breakfast. 1 o'clock is lunch, is 1 o'clock. So 11 o'clock, there is a walk for about 1 kilometer. Yes, it has to be done. So a day structure provides a lot of solace for the person because the person still has the capacity to learn at a slower pace. Initially, there may be resistance, but the people, I find that in the institutions where there are now people who are in residential care of dementia, usually they are brought by the family members because they are not able to handle them. 2 or 3 people not able to handle them. They come to a setup of 20 people with 1:4 caregivers. Each caregiver has about 3 to 4 people. But within a week, many of them settle down because there's so much of structure, like a military regimentalization in many of them, and people settle down very well with that. Okay. Sleep hygiene, again, because circadian rhythm disturbances is very, very important and very frequent. Physical activity, this is one thing. Exercises, physical activity, light exposure, very, very important. So people need to go out for a walk, need to be in the sun, and then do some activity because it helps them not only in BPSD to spend their energy, it also prevents falls. And multisensory stimulation, many of the daycare centers, you would find that there is a multisensory stimulation. There'll be music, there'll be puzzles, there'll be walking. So all these things, touching, like you see in blind schools, touching various types of textures, and then some sort of a small things like, how much is 3 plus 4? If you minus 2 from 5, how much do you get? All these things. So music, pets, gardens, massage, reminiscence therapy. I think it was very, very popular earlier days. Not so much now because, see, reminiscence therapy, validation therapy, these all need training. And now we have Dr. Sridharan Vaidishwaran of SCARF is doing the cognitive stimulation therapy of the UK, and he runs workshops on that. And it is a very good thing. It is not only for dementia, but it also brings down the BPSD. And I'm sure he would be assessing all these things, and we will have papers on them later in about 2 or 3 years' time. Because cognitive stimulation, and he also gave us, a small video of how it is done and how it helps. So it is for people with mild to moderate dementia. So reminiscence therapy and all these therapies need some amount of training. Then we have the robos now, and transcutaneous nerve stimulation is something with all the other neuromodulation that is also catching up. Acupressure and snozelin. This is now again one of the new things where it is used across all ages, where you have rooms like this with a lot of light, though we talk about not too much of light. Apparently, some of these lights are very, very therapeutic. Probably it needs the input of a very highly specialist person, because the light should not stimulate and then make the person anxious. But these rooms are all considered to be highly therapeutic, and I have never visited one of them. It's probably in the Western worlds. Okay, so they come under, according to Van, they come under 3 areas. Any therapy, either it is sensory or movement, and the last one is cognitive. Cognitive stimulation is you do some cognitive activities like puzzles and things like that. But mainly it focuses on sensory and movement parameters. Okay, so I think I have already talked about it. This is all from Bangalore. Whatever pictures I'm showing, they are all from Bangalore. Okay, so this is definitely not Bangalore. Okay. Music can be extremely powerful. You know, people who have learned music, I am sure most of you know that MS Subbulakshmi herself had some amount of cognitive disturbances, vascular dementia, but I think she did very well when it came to BPSD. She hardly had any. Okay, now let us look at this meta-analysis. So you would find, I am not able to see my right side, but I have read it quite a few times. So this meta-analysis very clearly has looked at various RCTs of non-pharmacological treatment. And the only one thing which sort of seemed to help is the music therapy. You can say here, this is the moderate one. I'm not sure but where it says music, because I have read it quite a few times. Probably I have. But if I have left it out, I'm not able to move here and there. If I have left it out, just go back to this. I've given it here. It is in psychiatry investigation. As far as I could see, the only thing which seemed to have some moderate effect was music therapy. All other therapies were very low in their effect. This is a meta-analysis based on RCTs. All right. So we need to remember that. Of course, they all say that they were so heterogeneous that we could not make them into a very, very combined, assessment and then, come to a conclusion. Yes, it is useless or useful, but whatever we could do, it shows that music therapy is the one which is moderate in effect. I hope you are able to read the, Ra et al. Psychiatric Investigation 2019, non-pharmacological interventions in BPSD in dementia. Okay, drug treatment as a last resort should target specific symptoms and not generally, there is nothing like a prophylaxis of BPSD. Regular review, especially after 6 weeks and after 12 weeks. Okay. So let us look at various things. For mood symptoms, are we going to use antidepressants, mood stabilizers, and for psychotic symptoms, antipsychotics, and non-specific things like agitation and aggression and disinhibition, are we going to use antipsychotics or antidepressants? And sleep disturbances, what are we going to use? So these are all based on various, cholinergic hypothesis and serotonergic hypothesis. I'm sure you know about it. Things have changed from the time we started to now. Okay, so now we need to, again, as we said, we need to sort of go through the psychiatric diagnostic method and find out whether the person is just having a depressive symptom, or does the person have a syndrome. And if there is a syndrome, use those drugs which have been found in people with non-dementia, which especially elderly. Use that. Only thing is, use those drugs which have minimal side effects and at a much, much lower dose. Choose drugs which are not going to be interacting with other drugs which an elderly would have. These are the main guidelines of choosing a drug. So choose those drugs which are being found to be useful in people elderly without dementia. Okay. And continue to treat the underlying cause. For example, if it is a pain that is causing the depression, treat the pain. If there is a fracture of the hip of the femur, set it right. So those are some of the things which people need to simultaneously do that. And try not to use anticholinergics like, triaxiphenyl and benztropine. So because they will definitely interfere and they are responsible for making the cognitive functions worse, and probably the BPSD also can worsen. Okay, so these are some of the rules, but I will also go in the next slide what is being done now. For example, antidepressants, citalopram and escitalopram, sertraline, but you will find that sertraline is no longer, now they feel that sertraline is as good as only placebo, whereas escitalopram is good. Venlafaxine, when there is a, there's also an associated pain and you need activation, but of course you need to sort of be careful, especially with venlafaxine, and also stopping it is a very big difficulty. Bupropion, switch to mania. If the person has bipolar, all those things need to be kept in mind, whatever you would keep in mind for other people. Trazodone, I do not know how much you use, because in the Western world, I have not seen trazodone, for example, in Australia and all. Trazodone is not at all available unless you make a very specific request, but it can produce hypotension, but it is very helpful both in depression, and also you would find that it is helpful in sleep related issues, and also in aggression or agitation. Mirtazapine, again, we need to be careful, but we use mirtazapine quite a bit in elderly with depression without dementia. And meclobamide, I have never found meclobamide very helpful anytime. So probably, if you want a very, okay, fine. So anxiety, I think I would rather start with citalopram, because you would find in the meta-analysis that citalopram mainly is very, very good. Okay, so for the sleep disturbances, sleep hygiene, non-pharmacological. So some of the things are, now people use a lot of prozazine, trazodone, prozazine, zolpidem, the problems of zolpidem, that it can give rise to parasomnias and things like that. But not everybody gets it, so can be tried, because it's a non-benzodiazepine one, and benzodiazepines with a lot of care, because it can produce a lot of falls. So keeping patients awake during the day, keeping them active, or giving a very short nap, early, giving more activities during the evening, and if they are awake in the night, to make them get up and then sit, rather like the stimulus CBT, and bright light exposure during the day. Okay, antipsychotics for BPSD, if it is delirium, now the drug of choice is risperidone. Earlier we used to use haloperidol, no longer. It's mainly risperidone, especially in UK and in Canada. US doesn't talk about it, and it is not FDA approved for that. And when we looked at, and Krishna Prasad is here, when Krishna Prasad and others did an audit of the drugs used for psychosis and agitation in the geriatric clinic, the most common drug which was used is quetiapine, and we are able to use quetiapine these days, start with 12.5 and you can go up to 200 milligrams. And that is something which is quite helpful. We use olanzapine and clozapine are not recommended, but people, I know that including myself, I use it. When somebody is jumping up and down and throwing things, we definitely use a rapid tab of olanzapine. And the other day I see now in some of the peer meetings and in some of the geriatric meetings, people are talking about clozapine 12.5. And I see somebody who's on just 25 milligrams of clozapine for the psychotic symptoms. So if it is delirium, risperidone can give quetiapine as an add-on, but all the other drugs are only off-label and not on-label. So this is a algorithm, and it's a good article for aggression and agitation. So you can see now what are the other things which have come from 2019, 18, 19, risperidone, aripiprazole, quetiapine, which is what we also found. And now sodium valproate is a definite no, 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 no. Carbamazepine, citalopram, gabapentin up to 1800, citalopram up to 1000, up to 20, prozazine, and then combination and ECTs. And for PRNs, lorazepam, I think that is more used than trazodone. And I think, so that along with the treatment of the Alzheimer's dementia, because that is very important, you would find in one of our studies earlier. So this is the pathway for aggression and agitation rather than anything else. No longer olanzapine. Okay. And even there, if you look at it, the green blocks are the one which have some sort of a proof that they can be used, which is risperidone and quetiapine. To certain extent, efficacy is only risperidone. All the others, the greens are, easy of use, less side effects and all those things. So you should understand that risperidone, but often people cannot tolerate it. So, but still we use it. So dealing with aggression and agitation is a very difficult thing only with medication. That's why we had the Bendigo Health, the algorithm of what do you do when somebody becomes agitated or aggressive. So you can see efficacy is green only in risperidone. Time to onset, probably all the others are all right. But all of them are only, okay. So this is what we need to sort of understand. Gabapentin and prozazine are something new. Carbamazepine, which was not one among the choices, have come into the fore. And this is by this study was done. It's not even a study. It is like a semi-Delphi. And they went around certain hospitals, inpatient hospitals in Canada, and they have done this. Okay. Not everything will work with every person. Key is flexibility. So look around the environment and look at the person also. Okay, we did certain studies. When we started, this is in 2004, and she must have started the data collection in 2000. So 35 patients with mild and moderate dementia. We put them on donepezil who had BPSD, donepezil, no donepezil, because we were planning to start them later. Okay. And we found that definitely those people who had donepezil did better, especially the NPA also, they did actually better when they were on donepezil, but those people who were not on donepezil were continued to the same. So this is something which we did long time back, and we did not, these are all outpatients. None of them were inpatients who were not given either at the time quetiapine or risperidone or anything like that. So addition of donepezil in a person with mild and moderate dementia for BPSD seemed to make a lot of difference. That's why we always say, just continue the dementia treatment. And positive responses were there in a lot of other things, ADL, nighttime behavior. But other things like disinhibition, eating, apathy and all did not change. We also did another study where the person will be on donepezil, will have some BPSD, and we add memantine, 20 milligrams of memantine, and see the difference. It didn't make any difference at all. Okay, so, but what in an analysis of a very small number of person with severe dementia, it made some changes in the BPSD, but on the whole, it didn't make. Adding memantine did not change BPSD. So what came through was a person with mild to moderate dementia can benefit by anticholinesterase inhibitors even in their BPSD. Okay, so this is my last slide, I think. These are things which will respond, whether it is medication or whether it is, environment manipulation, non-pharmacological, wandering, inappropriate urination and defecation, dressing, undressing, annoying, usually not responsive. Okay. Repetitious behavior, and you would find that many of them are a part of your FTD. So these somehow will not respond. Anything which is repetitive and slight disinhibition doesn't seem to respond. So all of us need to, as professionals, because we are all professionals, what is important is you are not able to see the key aspects of care is that there should be a person-centered therapy approach, multidisciplinary, legal and ethical. Understand the priorities are understand factors, manage physical needs, environmental and behavioral management strategies, both in the environment or also the person involved. Psychological, there should be an engagement, cautious use of psychotropic, and care for the carer. In the end, we always should care for the carer because that the person should not burn out. All right. I think with that, I stop. I'm not sure whether any questions are welcome. I hope I have kept to the time.
Thank you very much, madam. Thank you very much, madam. Any specific questions, you can please unmute or you can type in the chat box. As of now, there are no questions in the chat box, ma'am.
Yeah, one of the things which I have always found is that anything which is behavioral, people think it is a common sense approach, and it is, so anything, it doesn't need a professional intervention. But when it happens, often, you know, people are always foxed by that, you know, how to deal with that is something which they always, and of course, many people either refer them to a psychologist. We do not have geriatric psychologists. I do not know whether there are geriatric psychologists in India who are practicing, who are, I know Ravi Kesh did his work in PhD thesis in geriatric psychology, in geriatrics. So somebody who would be able to sit and do a lot of behavioral analysis, because these are all very, very, whereas in the Western world, you have behavioral psychologists who will come as a consultant, sit for about 48 hours, look at the person and provide the setup, the unit for suggestions to implement when there is a lot of aggression, pacing and things like that. So there it is a very specific one. Here we sort of trial and error, we do things.
Yes, ma'am. Chandra, madam, any specific comments or suggestions, madam? Vengama, madam.
Totally refuse to take medicines now. And how to make them take even some basic things, even regular medication, some of them very difficult to give, like BP medicine, heart medicine, and that they refuse adamantly. So such patients, how to deal? Many methods we have tried, mixing with milk, honey, all sorts of things, but finally they die due to their primary metabolic diabetic ketoacidosis.
Yes, madam, because not all medicines can be just added and given, isn't it? Many a times we have the same issues with many of our paranoid patients who refuse to take medication. And as many a times, India is also criticized for stealthily putting medication, taking the control of the person in our hands. So there is a lot of criticism the world over that how we add medication. So it is in such a person, it's only the, I'm not sure whether you have to go towards a palliative care, that they are so severe that they are palliative care and they want some sort, these people are so severely upset about their own conditions that they would rather pass on rather than remaining and suffering. And do they have that right? We do not have advanced directives here. So it's very, very difficult. On the other hand, if I am a person here, because the concept of advanced directive is not coming, and if I'm going to write today saying that if I get dementia, stop all my medication. And if I go into a cardiac arrest, do not use a fibrillator. And if I go into a respiratory arrest, do not use a ventilator. So, and I sign it and I, sort of use it. And there are people, lot of people who will, everybody will come with many of them will say that it is part of my advanced directive and I have a right to do that.
Madam, this we have one patient. She will simply order cakes and breads for in wedding, like frontal lobe syndrome patient. She is a person who lived in some other country. She is used to ordering food materials through online all the time. Now the big problem for the husband is she will buy cakes for a wedding. He won't know what to do. Now that kind of regular purchase he is doing. Very
She
tough.
cannot block her account.
Well, that I have to ask, I think.
Yeah,
Legal
because
problem, no?
yeah, because it is a legal issue. Because this is something which we have, Vivek may not be there. We use that in people with alcohol dependent syndrome, and many of them will work in factories. So some of the factories would collaborate with the HR person and not give the money. I'm talking about, where money is still given in hand, not giving it to the person, but to the wife who would go and collect it on a Saturday. Okay, of course, he would beat her up and then, grab it. But many a times we can even block. But he needs to take the advice of a lawyer, because if it is her money and if it is a joint account, he has a right. But if it is her money, then I do not know whether he can, even in India, he has the right to block it.
Psychologist who studied in Manipal and working in some UK. So she is very rich. She is having a lot of money, madam.
Money, yeah. So if
Her
it
money,
is her money only, then it is going to be a legal issue. Somebody else may file a case saying that he is not allowing that. So many of these things are needed. That's why we say that many of these things need a lot of planning earlier. What happens to me if I get dementia? What happens to me when I have a cardiac arrest or a stroke, or when I lose my speech? So people in their later 50s and 60s need to plan about some of these issues. And that's quite important. But that I see, madam, in a lot of people who have dementia in the Western countries, they have an advance directive. And usually they will also nominate their husband or live-in partner or a daughter or a son, and they would have nominated them. So we are able to sort of work in some of those issues. So, but we do not have that here, because it's advance directive is not a legal thing here. So we need to do that.
Thank you,
Many
madam.
legal issues are there when it comes to dementia.
Madam, there's one more question in the chat box, madam. In a patient with the dementia where behavioral symptoms are secondary to psychotic symptoms and the patient refuses to take any medication, are there any guidelines on the usage of depot antipsychotics?
I don't think so. If the person has been using a depot antipsychotic and now continues and then has become, as a person become, because I had a patient, what he's talking about, I can understand. I had a person with whom we were treating for schizophrenia. Unfortunately, she developed schizophrenia, dementia. And when she came to us with dementia also, because she was a person with resistant schizophrenia, she was on clozapine actually. We continued the clozapine. Yeah. So this person, and she was psychotic. She still had psychotic symptoms. Only thing is it no longer bothered her. And so I don't think that to start newly long-acting drugs, I'm not sure. What people have done, I have heard in some of the peer reviews, is start them on clozapine 12.5 is something which they, I've not done it so far. But long-acting, no. Because long-acting, adverse effects are so common in elderly. What are the long-actings we have? We have, see, for olanzapine, you need to have a supervision for about 4 hours after that. That's very important. Okay. And the other things are all, whether it is risperidone or the earlier ones. Aripiprazole, yes. Aripiprazole, I'm not sure whether aripiprazole, you get it as an injection here, because you have it in Western world. Aripiprazole is all right. But to remove, if something happens, especially Q2 interval prolongation and all, you just cannot remove the drug. And we are talking about not using the drug for more than 6 weeks and to a maximum 12 weeks, if it is BPSD, not otherwise.
Okay.
So how will you remove it? Very easily. When you stop it, of course, it tapers off on its own. But when people who have handled people with dementia will know how difficult it is to handle somebody with BPSD. And that's why, otherwise, this is not a profession where psychiatrists should be in. It is because almost all of them have BPSD that they come to us. We share the table. Otherwise, we will not be there with the neurologists. And it takes a lot of time. It takes a lot of time to, sort of assess, describe, intervene. And every time, sometimes it may have work for some time, and then thereafter it may not work. So you have to choose something else.
Like Madam told music. When we were in NIMHANS, only one patient from Manipuri, madam. She was bedbound lady with advanced dementia. Actually, that patient was published also. It was very surprising. She was a dancer who used to sing, and maybe Ravi Teja knows. Thomas and all knew. We are part of that publication. Thomas was there. But she was bedbound, incontinent. The actually husband thought she was being ill-treated in the office, so she became demanded bedbound. So he thought some remedy may be there. He was not willing to accept the diagnosis of advanced dementia. Then when we told just to play her, she was a singer and a dancer. So why don't you play? Then he was telling he cannot even eat or bath or toileting. She cannot do. Why you want me to play music? How she will dance? It was very surprising. Like it was in that B block. Suddenly she lighted up. The whole room became bright. Like she jumped out and started humming. She forgot the words. Some Manipuri song he put. She started humming, and within 1 week or 10 days, there was so much change. She cannot become normal, of course, but she was communicative, and she tried to do some of her activities, and she was dancing also. The bedbound woman, and the room lighted up, madam. Puja, all those people were there in that room at that time. It was so mixed, like, I always feel that it is not lost. Information is not lost. It is there somewhere. We don't know how to retrieve it.
We do not know how to open it. It is locked for us. It is not locked for the person. The person has no ability to communicate that. Yeah.
Thank you, ma'am. Matthew, sir, your expert comment, sir. Vishnu Prasad, sir. Matthew, sir.
Nothing specifically, Ravi. I think Srikala has covered everything.
There are there are wonderful meta-analysis and systematic reviews on each aspect of this now, starting from 2018. I said 2016 was Vance, and then 2017, and then Rao was 2018, then Davis was 2019. So you have a lot of work now, people who have looked at various aspects of BPSD.
Yeah, there are Cochrane reviews on almost all types of BPSDs and different kinds of interventions also, from touch to music to aromatherapy to reminiscence to light. I mean, there's Cochrane reviews on everything actually. But just a couple of things about medication. I mean, to what Dr. Chandra asked, many medicines are available in liquid preparation. So you can give some of them as liquid. And I know many patients, relatives who powder the medicines and give it in honey. So, I mean, I think we have to use the sort of adage that when they have dementia, especially severe dementia, they are not able to take a decision to take care of themselves. So obviously somebody else has to do that. As Srikala said, the best way to do it is to have have a court order and say that so and so is the guardian. But that can also be done now with the new Mental Health Care Act. There's provision for maybe a quicker provision for guardianship, and also quicker provision for having advanced directives as per the new Mental Health Care Act. Of course, the rules and each state has to form the commission, Mental Health Review Commission. But I think it will happen in time. But I think for many of our patients, patients get medicines whether they like it or not because the family member gives it. So, in fact, the problem is that on many occasions when we write some medicine, quetiapine or whatever it is that we write, they don't stop. Even when we tell them to stop, they go on giving it till the person dies. So that is one problem that I find in our country, that people can get the medicines over the counter. And so that might be an issue.
Yeah, in England and all, especially for BPSD, using antipsychotics and Sube and all, so much of work against that they should not be used. And there are movements and then policies and advocacy and policies based on that.
Yes, ma'am. Girish sir and KP sir, Krishna sir, any specific comments, sir?
Nothing from my side, Ravi. I think Madam has covered most things and sir has added.
Yeah, thank you, sir. Ma'am, there's a question in the chat box, ma'am. Can donepezil reduce behavioral problems in long term for a patient with moderate to severe dementia?
That's what I was just trying to say. In our study, we found that in mild and moderate, it definitely decreased the BPSD. But donepezil is not going to stop somebody from, going from mild to moderate to severe. So it only slows down the process. Nothing is going to reverse the process or, make it stagnant or whatever it is. Once they become severe, yeah, it didn't make a lot of difference. And that's why we talk about probably an addition of memantine. There are two things which now people have tried. One is giving a higher dose of donepezil, now, 21. That is 10 milligrams. So you give 21 milligrams. So we did a study on that also, if I remember. Okay. And then also add on memantine and then continue. That's why when you look at the BPSD pharmacological intervention, you will also say that continue that. But in the Western world, for example, UK and all, or even in Canada, they will say that stop, because it may not be, because these are countries where the medicine is provided by the NHS, the social, where the social welfare countries, they may not give you the medicine. They say that it has not helped. The person has gone on to severe dementia. So there's no need for that. Whereas in US, still people can get it because it's a HMO managed one. So not all countries also recognize the relevance of cholinesterase inhibitors and memantine in severe dementia or profound. Because if somebody is profound, naturally they are bed-bound and everything, people are going to stop. It becomes a palliative care. Severe, yes, there will be a lot of behavioral problems, starting from not eating, extremely apathetic, all those things will be there. Severe dementia, yes. Most of the ADL will be lost. Cognition will be lost. Probably speech will be lost. So because of all these things, the restlessness, because they are not able to communicate or understand anything, the disturbances, but if they are mobile, the disturbances will be there. We can use it, but I do not know whether they are really in RCTs they have found to be, if you gave only these two, that it was effective, no.
Thank you, ma'am.
So Srikala, just to add on, I think the earlier studies showed that donepezil and memantine, the RCTs showed that both of them actually reduced NPI symptoms. So one of the, I think to this question, can donepezil reduce behavioral symptoms in long term for a patient with moderate to severe dementia? I think what is usually recommended in many guidelines is that you start with other interventions but you start donepezil and memantine straight away in a person with moderate dementia. And usually in 3 months' time or so, if donepezil and memantine are going to work, it will start working after 1 to 3 months. So by the time donepezil or memantine starts working, you should actually take off your antipsychotics or antidepressants or whatever it is that you're giving. Of course, as Srikala mentioned, the first line of treatment is non-pharmacological. But just to sort of mention to this question that there are RCTs which show that NPI symptoms respond to both donepezil and memantine.
No, his question is severe.
No,
Suppose somebody
severe.
is already in mild and moderate, and then he goes on to, this person goes on to become severe. Will it continue? I'm not sure, because what happens is in certain countries, it is not allowed. Like in UK and Canada, mild and moderate, yes. Donepezil itself is helpful. Adding memantine is also helpful. And we have also had people saying that memantine helps across all ages. But whether it is approved is a question. Because I think both, they are quite expensive in some of the countries. Rivastigmine, of course, the other one is the rivastigmine. Donepezil may be cheaper, rivastigmine, and memantine.
Thank you, ma'am. One more question in the chat box, ma'am. An elderly patient suffering from BPSD currently presented with delirium. Do we need to stop antidementic drugs? Do anti-dementia drugs has any effect on prognosis of delirium?
The delirium, if we are thinking about delirium, it is going to be a very brief, because you need to identify the cost. Somebody cannot be in a subacute delirium for a very, very long time. That's not, because delirium by definition is an acute onset, even if it is on top of a dementia, because of certain physical issues. And then once that is identified, it should come down, is what it is. And what we are not only treating the cause, which should actually take care of the delirium, but if a person becomes very restless and difficult and anxious and things like that, then we talk about adding a small amount of quetiapine, whether risperidone or quetiapine. Okay. So during this time, I have not asked anybody to stop the medication. They continue. I'm not sure whether people ask them to continue, because I've not seen cholinesterase inhibitors being responsible for any delirium. If that is the source of the delirium, hyponatremia, pain, constipation, urinary retention, infection, any of these things could be.
Thank you, ma'am. Giri sir, any specific comments, sir? Any senior faculty, Vengamma madam?
Frontotemporal dementia patients, when they are suspected as a frontal variant of AD, and they are put on cholinesterase inhibitors, they go in for delirium. Because there is no acetylcholine deficiency in them. And cholinesterase inhibitors are hallucinogenic. And FTD patients, they go into problems when they are by mistake given. And there's some article where I studied by 1 year, one brand of cholinesterase inhibitor does not stabilize at least the behavioral component. Like madam told, cognitive components do not improve. It's the behavioral components that improve. If it doesn't stabilize by 1 year, there is no point in continuing that particular cholinesterase inhibitor. You'll have to try alternative. It might help for some time, like that. Recommendation I cannot exactly quote, but I definitely read an article like that. 1 year, if there is no stability in the behavioral components of the patient, then you'll have to try changing to rivastigmine or galantamine and see.
Madam, one of the biggest problems, if you see in most of these BPSDs, of course, Alzheimer's dementia is one part of it. And the other aspect, which is mainly very, very difficult, are the people who are frontotemporal dementia. people who have, because there are people who are put on cognitive cholinesterase inhibitors and then SSRIs because there are repetitive symptoms. So, or on antipsychotics, and all of them, none of them helps. That's why you find that some of the things which do not respond have many of the things which are from frontotemporal dementia. And fortunately, frontotemporal dementia is not as common as Alzheimer's dementia. Most of the things of anything to do with, and they are the people with a lot of behavioral problems. And none of them seems to respond to any of these things. It is only the behavioral non-pharmacological interventions which can help. Because I have seen people, we have tried, none of them helps actually in people with frontotemporal dementia. Just as CEIs do not help, other things also equally do not help.
Thank you, ma'am. One more question in the chat box, ma'am. Are rivastigmine and donepezil different with respect to effectiveness?
I think I would ask Madam to do it, because that will be better, because I know that this rivastigmine is supposed to have this, used in, I think Madam, if you can answer that question. I know donepezil is much more time tested, one of the earlier drugs as a...
Also a cholinesterase inhibitor, only thing it acts through different receptors. It acts through different receptors. So when donepezil, all ultimate mechanism is increasing the level of acetylcholine. But acting through the receptor is different. So if donepezil doesn't help, we can try the other modes. Another thing is rivastigmine can be used as a patch also. So for patients who refuse to swallow, that can be used instead of donepezil.
One of the things they were also talking about is the not only acetylcholine, but it is a double action of butyrylcholine also is sort of comes into picture when you use rivastigmine. Is that?
Yes, madam. Yes, ma'am. And some antioxidant properties.
There are a couple of old studies which possibly indicate that rivastigmine and galantamine might be useful in the DLB and Parky dementia. So, I mean, that's really, I think, very theoretical. There's no studies after that which shows that they're more useful. The studies which show that donepezil is also useful. But some early studies were there saying that they were useful for DLB and Parky dementia.
DLB. I think the studies were with the DLBs.
Thank you very much, ma'am. I think there are no other questions in the chat box, ma'am. Thank you very much for a very interactive discussion. So if there are no other questions, can you please end the session, madam? Srikala madam, Chandra madam.
I should say stop sharing. Yeah.
Yes, ma'am.
I'm done.
Madam, I think if there are no other questions, can you please end the session, madam?
What should you're asking me or Chandra madam? I'm not sure. When you say madam, I don't know whom you are talking about.
I have both yourself and
yeah. I just thank all the participants for being here on a Sunday evening and listening to this. And I think it's a good forum where everybody comes together and then learns as a group and from the comforts of your own home. And I thank Ravi, you for taking all the effort and also Madam for having us as a part of this. And I thank all the participants. Thank you.
Thank you very much.
Thank you, madam. Thank you very much.
Thank you,
madam.
Very
good attendance, madam, reaching 85 to 90. Thank you very much for all the participants.
Sessions was very insightful, and all of us, we enjoyed the session. So thank you for sparing your Sunday time with us and enlightening us with the management of BPSD. Thank you so much, ma'am. And
You're
also
welcome.
thank Dr. Matthew sir and S.R. Chandra madam for insightful suggestions and interactive sessions with us. Thank you so much.
Thank you all. We can end the session. Thanks.